Hello, good afternoon, everybody. My name is Priscilla Andrews. I'm the clinical manager here at the Cancer Wellness Center, and I want to welcome you to this month's staff chat. The staff chat was designed as a series to give you some insight into a conversation between two professionals, or sometimes three, talking about topics, issues, concerns that are relevant for the cancer community. So thank you if you're joining us on Zoom or Facebook, or if you happen to be watching this on YouTube after Wednesday. And I am very excited today to have Katie Salyer here with me. Katie is a psychologist. Some of you may recall that she is a former clinical team member at the Cancer Wellness Center and is currently in private practice with 360 Wellness and Coaching in Lake Forest. So Katie, thank you for being here today.
Thank you for having me. Very happy to see you.
And the reason I wanted to bring you here today, and maybe some of those of you in the audience who are familiar with Katie may be familiar with the fact that Katie is a trauma-informed therapist, has presented in the past on trauma and the cancer experience. And since it's such a relevant, I think, subject to the community, wanted to bring you back. So thanks for being here for that.
Very happy to be back. Love the Cancer Wellness Center.
Did I leave anything out in your introduction that I should have included?
No, I think that about sums it up.
Okay, good. I always ask when I have somebody here for the staff chat, I always ask just to start out with, what interested you in this area? What drew you to the area of trauma in general?
Sure. Well, they say that we're in the field for a reason, and that's a little true as well for myself. My primary focus has always been health psychology. And beginning in childhood, I have managed to log a good number of hours managing my own health concerns. So really getting well trained in that role of a patient and being immersed in a family system that's also experienced that caregiving side very, very much so. So it's really been a very shaping piece of my experience growing up. And it always was really important to me to become involved in the community, to really provide support. Initially, I thought I'd be a medical doctor, but I came to learn after my quarter life crisis that I'd instead like to serve the community more in that social, emotional, kind of spiritual side of things. So when I entered my grad studies, I was very intent upon health psychology as my focus. And as we can see at the Cancer Wellness Center, very often those things come hand in hand with a lot of trauma and our brains and bodies and how they just experience that very human experience of being sick. So, yeah.
Well, and I think, just picking up on, you said that the trauma of the diagnosis, right? Because I think people don't always have an understanding of what trauma is, or maybe they have a narrow definition of trauma, like trauma. Maybe they think like, well, that's something that happens to soldiers that have been at war, or maybe somebody that was involved with 9/11. So they kind of discount those experiences that maybe would fall under that umbrella. I'm just curious how if you have somebody that comes to you dealing with chronic illness, dealing with a cancer diagnosis, and don't necessarily see it through that lens, how you help them kind of conceptualize that.
Sure. Yeah, that honestly, I think is a pretty consistent, almost unavoidable conversation I'll have with folks when I talk about health, cancer as a diagnosis and treatment, and how that can very readily be seen through that trauma lens. And the definition of trauma really is much more it's much more expansive than we first think. Certainly it is a trauma to be in a war zone, in the trenches, or in 9/11. But trauma is really any occasion where the stress load that we're under overwhelms our system and capacity to manage it. And that can show up in a lot of different ways through cancer, particularly. Acute traumas can happen in that moment you're in the ER and you get the overwhelming news of a diagnosis that you didn't see coming. Chronic trauma which is usually something defined more as that sort of long standing over the course of time. Chronic trauma is very common when you're in months and months of treatment, and your system is run down and that stress load gets, higher and higher. And complex trauma is another lens you could consider cancer through. And I think sadly, 2020 is a good example when you're encountering cancer as a diagnosis in a pandemic. Now we're talking about a complex trauma where multiple unique stressors are overlapped on top of each other. And, that also could be examples to include financial hardship, different experiences as a marginalized individual or person of color, and just even the state of the nation can be very stressful. So all of these different factors overlapping on each other amidst a cancer diagnosis can very readily create a complex trauma.
Yeah. Well, and I think something that I'll often talk to people about is like little t versus big T trauma. And I think, people are more familiar with the idea of big T trauma, like some major event that's sort of almost time bound. But the idea that there can be these, almost like a death by 1,000 paper cut situations that culminate to have a deep impact on people.
Absolutely. And I think that's often how cancer can go a little bit more under the radar, because it very often is very chronic. It does occur over the course of several months of treatment. And so it can be helpful to talk about that through that capital T, small t kind of consideration. But ultimately, the other example that I'll give folks is whether you drown because you're in 7 feet of water, or if you drown in 70 feet of water, it's all drowning. And that still is sort of the example of, there's always just a point and a threshold at which our bodies ultimately, they get rewired. They're essentially hijacked. The brain and body hijack normal kind of programming and put in place this sort of survival programming, which at the moment is very protective, very functional, very adaptive, very helpful even, but can create some consequences in the long run.
Yeah. Well, and I think something you just made me think as you were talking is I think there's an idea that if people were like stronger or more positive or whatever term you want to put in there, there's this concept that it shouldn't be traumatic. Like I should be able to handle this. And that if it is traumatic and if I am having this response, I think people can go to this sort of shame place of like, there's something wrong with me.
Mm-hmm. In truth, shame can itself be a pretty good predictor of some trauma. Shame is something that can be really well interwoven in the experience. It's very isolating. So if someone's experiencing a lot of shame or that sort of self-critical place, those are good indicators of maybe chatting with a professional or kind of looking into things further, because they can often go hand in hand with trauma. And that is one of the most important jobs I hold as a professional, is helping someone move through that shame, come to a place of better understanding. That term self-compassion, if you've ever worked with me, is one that I'll throw out just about every 10th word. Self-compassion, because that is a very healing brain process. It's a lot of trauma is about the physiology of what changes in our brain, and shame is a very particular set of structures. The more we can incorporate self-compassion, self-understanding, we're incorporating other brain structures that really heal and rewire and change our bodies in a way that move through that trauma, complete the trauma cycle, heal that sort of trauma cycle. So I think that's a very common experience to second guess. Maybe I'm weak, or I'm not doing this right. The woulda, coulda, shouldas. I think it's also very unique and particular to the cancer community. Sometimes there's a lot of that sort of toxic positivity that can come through, in the expectation that cancer has to be a gift, or you have to come out on the other side somehow renewed and invigorated into life, and
growth experience. Katie, didn't you know that?
Sure. Yeah, the gift that keeps on giving. Yes. Yeah, and I think those messages are great if that's what comes naturally, and if that's what your brain and body can eventually come to, but it's perfectly okay to not like cancer, which is a funny thing to have to like reiterate for someone, but you don't have to like your trauma. You don't have to like cancer. You don't have to feel good about what it's brought you. That's not necessarily your end goal in trauma work.
Well, and I think there's a sort of, it can be so counterproductive, because if how you're responding to the experience is one of a trauma reaction, and then you're just trying to shove it down your throat that you're supposed to be positive, that this should be a growth experience, that, you know, that myth of the cancer survivor is what you should be taking on. I think the reality is the deeper part of your brain recognizes that there is a fallacy to what you're trying to shove down your throat.
Absolutely. Yeah. I think, our bodies are sometimes smarter than we give it credit, and it will sniff that out. It will sniff out that falsehood that, I don't love this. I don't even like this. This is miserable. And to try to tell myself anything other than that, honestly, actually can cause further damage in truth. A lot of trauma work is about integrating, some folks talk about it as integrating different parts of yourselves and coming to accept that maybe there even is a possibility that there could be a teeny tiny silver lining, but that doesn't have to win out or be a bigger part. You want to actually include and integrate the other parts of you that also can see it is painful, it is isolating, it is overwhelming, that can really come to accept the darker sides of, and you'll generally be more likely to find that post-traumatic growth, that silver lining, that gift of cancer, if you decide to see it as such. You'll be far more effective in reaching that if you also allow in. You can't pick just the good feelings, you can't close out the bad ones. Trauma work kind of encourages us to get back in touch with the honesty of all of what our body is saying, which is, this stinks. And then maybe at the end of that, by moving through that, by letting that get released, by letting that get processed, sometimes the outcome can also be, it does stink and I can make the best of it.
And, I think something that you've been bringing up as you've been talking about physiology and talking about the body, and the mind. I mean, I think some people feel this sense of like they can kind of just talk themselves out of it or into something, that it's a cognitive process only. Well, you know what I think about that, but why don't you share with the people listening what you think about that?
I have lots of thoughts about that. We could go on for quite some time, but I'll take the opportunity to show everybody the brain once again, and how, when you're talking about this cognitive self-talk, there we are. Thank you. I folks who work with me tend to see the brain a lot. There you have your amygdala tucked underneath, and this frontal lobe over here, down to the more primitive parts of the brain, and that sort of brainstem into the, and so when we talk about self-talk, it's valuable. I want to certainly be supportive of, and really encouraging to folks who use that and can really harness that and hone that in a way that they really can move themselves through different things. I also want to recognize that self-talk really lives in this frontal lobe part of the brain, this really, very highly developed part of the brain. And trauma is something that is really limbic based, meaning it's a lower part of the brain. It is more primitive, it is more automatic. It's also helpful to be aware that trauma also lives on a cellular base, really in our bodies. You'll hear all the time about how the body keeps the score, the body remembers. And there is evidence of that everywhere. Our fascia, the tissue that connects our different organs and just muscles and everything in us, actually has this very low level automatic primitive programming that holds that trauma fiercely in a protective survival mode kind of sense. So self-talk can be great and helpful, but you're kind of working against the grain of the brain. You're trying to use this high level thinking to build and deepen roots downward into the brain, when in actuality, trauma work often is built from the bottom up. It's that bottom, the signals that you're going to get, the automatic responses that you do, will all come from the bottom up. So it's not so simple as to say I can just talk myself through that. I can think my way through that. It's a very involuntary process. And there are examples of that all over the cancer community and in any work. I'll have individuals who automatically freeze at the sound of a ringtone because it matched the ringtone to their nurse's station. Individuals who were reduced to sobbing because they accidentally came across the camisole that they wore because at the same time that they had the drains and tubing from post-surgery. And certainly smells are, they are straight shot right into the brain. You get the whiff of, everybody knows that smell of the hospital, and it brings up a visceral reaction. Just even talking about that, I can imagine many of you are able to reflect on that automatic visceral reaction of the smell of that sterile hospital environment. And it's just the way that we're wired. It's a safety mechanism in our body and brain that will program it far lower than this frontal lobe can reach. So self-talk is great. Keep it up if that's of use to you. And maybe I would encourage folks to be more, once again, self-compassion, have that self-compassion to know that you can't just will your way through trauma. Sometimes it's very automatic. It's very involuntary, the ways that we will respond to the environment and stimuli around us.
Well, because that deeper part of the brain has a faster reaction time than the prefrontal cortex. So we're really always playing catch up to this survival part of our brain. I think the thing that I often will talk about with people is like the idea of like stress, anxiety, is it neck up or neck down? If it's just neck up, then you can remind yourself of the thing your doctor told you about, how unlikely it is for a recurrence, and then you stop thinking about it. But once it's neck down, you can talk to yourself all day long, but it's unlikely to be sufficient because now it's just this whole body process going on that you kind of need to, it's like a fire alarm going off in your body, and you need to figure out like what's going to work for you to help tell the fire alarm, okay, we don't need you, thank you. Like the building is not actually on fire in this moment.
And we, part of a lot of trauma work that I do is really making folks more comfortable with that. There are a lot of woulda, coulda, shouldas, or, there's a lot of that self-critical voice that can come through thinking should be stronger, should be doing this differently. But the reality of it is we should, there's a should, there's good reason to be thankful for those survival mechanisms. That fire alarm, if we see it as a fire alarm, we all want fire alarms. We need fire alarms. We want to be alerted to do something, take action. And that's really what our bodies are doing when we have these trauma reactions as well. They're alerting us and making us aware that something has gotten a bit stuck. That's something we want to build some understanding around, make sense of, and if need be, we may need to respond to that. That's part of each individual's decision is through time determining whether that trauma reaction persists long enough or intensely enough that they feel the need to do more targeted trauma work on that.
I'm curious because we could talk about the cancer diagnosis, and that alone is a trauma, right? But then I think something that I encounter, and my guess is that you do as well, is that we see people because of the immediate trauma. And then when we talk to them, we find out about past experiences that maybe they've never even labeled as trauma, but really are trauma and coming to bear on their current experience with the cancer diagnosis.
Yeah, I really appreciate the direction you're headed there. We all are formed by all kinds of capital and little case T's all throughout life. If we normalize it and talk about it more on sort of a stress spectrum instead of just trauma, we all kind of are forged in fire from the moment we're born. And so these stressful experiences or relational experiences all teach us along the way, and they can sometimes log, kind of capital and little case T's along the way that, generally speaking, our brain, once it makes that neurons that fire together, wire together, once it makes, a route and sort of has a way of connecting certain life events, it's just going to take that pathway each and every time. So if a cancer diagnosis comes forward as a trauma, it is not always unexpected to find that it can replicate, or the way that that trauma presents, the way that stress reaction comes through will replicate sometimes things that have happened in the past. Because certainly there are a million different ways that that trauma can express itself. Maybe it looks more relational, maybe it instead looks more visceral, or, that there's really that startle response. And so oftentimes, if you're in touch with the trauma that cancer has provided or presented in your world, it also can be helpful to be thinking of what history has also, what other things have happened in history throughout life that may have some relevance, may be worth looking at. It's a little bit like following the breadcrumb trail backward to determine sort of that initial time where some trauma was experienced, feeling isolated or neglected, or feeling misunderstood, or any number of different things that it can happen. And ultimately healing one trauma is very helpful to healing all of trauma. So they're all interconnected in that kind of a way.
Yeah. Well, and I think too, I think that there's both the helping to understand how people are responding based on their past experiences, because how they're responding to this trauma, if there is that trauma history or that high stress history, how they're responding now probably makes complete sense relative to what's happened in the past. I think the other thing that I've noticed, and I'm curious if this has happened for you, is I've certainly had clients who sort of thought that past experiences were like put to bed, and then the cancer diagnosis comes, and all of a sudden they're being flooded with thoughts and memories of things that happened to them, maybe even going back to childhood, that had been sort of, it's like the pot was on the back of the stove with the lid on it, and they didn't think it was boiling, and then it just gets pulled onto the burner.
Mm-hmm. Yes, that is also a very common experience I'll encounter. It can be alarming for someone to think that they have moved through and made sense of and come to terms with a past trauma, and then unexpectedly it's right back in the forefront again, or it's intrusive again. You can't seem to put it back to bed again. But that is very common to trauma. And it is often the case that the way you're responding to what's in front of you, the trauma that might be, or the stress that's presenting itself in your present day world, can look very similar to the way that you were, that the environment around you kind of caught, the way in which you adapted to that scenario back then can be replayed, and perhaps this is not a smooth transition, but what you're saying kind of brings to my mind that series of different responses that you'll find in trauma. There can be fight, flight, freeze, fawn, and flop. And most folks are really only familiar with fight or flight. And those feel more recognizable. They're a little bit clearer. Sometimes fight can look like just being really agitated, irritable, angry, or really kind of feeling that sense of stress in the body, that tension. Flight can look like wanting to do anything and everything you can to avoid getting to that hospital, maybe going to take the extra long route to work because you just don't even want to pass by the treatment clinic. But there are actually a lot more complex responses that are sometimes a little more challenging to find or recognize, rather. Freezing is very common and a very normal and adaptive response for folks, in the same way that fawning and flopping are generally things that you'll see if there is that history of trauma in the past. But really, what you're describing is kind of getting familiar with your own personal stress response can be really helpful, because any, future stressful situations you'll find yourself in, whether it's cancer, caregiving, or otherwise, are very likely to look like those similar patterns that you had in any other traumas you might have in those formative years earlier on.
Mm-hmm. And can you say a little bit, for people who aren't familiar with the freeze, fawn, and flop, could you just say a little bit about what those states entail?
Sure. So it's not necessarily a neat and tidy sort of.
What? No,
I know.
It needs to be neat and tidy.
Yeah, neat and tidy is the way to go. Yeah, well, I'm working on it, but so not everything in, our brains and bodies can be very neat and tidy, but, fight, flight, freeze, fawn, and flop, these are all different responses that our body can be pre-programmed to provide in the right circumstance. And once again, they can be really frustrating or complicated or complicating, but they're designed to be self-protecting, and they're intended to be one way to adapt and really get into that survival mode. So we've kind of reviewed fight and flight briefly. Freeze can look a little bit more like being numbed out. I can think of any number of examples in folks, and it's maybe a bit more familiar in that acute stress situation where you've received the diagnosis and you're telling folks all around you and they all say like you're handling it pretty well, and in actuality you just don't even know what to make sense of it. Like it's not registering, it doesn't even feel real. It's very surreal. Freeze can look a lot like dissociation in some cases, but also just numbing out. Maybe, it's like trying to fit 100 pounds into a 5-pound bag. It's just not fitting and it's just kind of rolling right off. And we can think about the blissful, peace and comfort that can bring in that moment of extreme stress. This is why we want to really appreciate our bodies and how they protect us. Oftentimes that freeze response is normal to the shock, but if it persists over time, or if it kind of comes in at lower level T situations, that's a sign that that's more of that stress response in the body coming back, returning, and maybe interfering with a more appropriate response to what's in front of you, if that makes sense, kind of a more proportionate response. So that would be freeze. Fawn is a bit more of a relational kind of adaptation, where oftentimes if there is that history of some earlier traumas, it can be very adaptive to place your own needs secondary to others' needs. So in a household, perhaps with children who have complicated parental relationships, they may learn that their survival is best met if they set their own needs aside and address the needs of the adults in the home. So fawning happens and can look a lot like being a people pleaser. In a cancer situation, that may look a lot like, oh, why are we talking about me with my diagnosis? I'm fine. It's okay. Tell me what I can do for you. Or, I'm over here trying to get chemo, but, I can't do chemo because I'm too busy managing the mitten and the scarf drive at the school. I really need to focus on that. And there's a certain identity and a survival in that, where focusing on someone else or something else can feel safer, can feel less threatening, less dangerous. So that can happen and show up, and is typically really created earlier on in life, but shows up throughout other stressful situations in the future, or in adulthood rather. Flop is a pretty, can be a pretty extreme and complex situation. Flop is usually the last of those stressful and most it's the sort of the most intense response that our bodies will present in a stressful situation. In an acute setting, a flop might be literally passing out. If anybody's ever heard the news of a diagnosis or a loved one and was so overwhelmed that they truly just passed out, their whole system shut down. It doesn't happen too terribly often, but you'd be surprised. It can, and that's a good indication of just your body saying, nope, too much. I'm gonna just take the break myself. I'm gonna go ahead and take a moment. Flop, however, can also be something that kind of gets when under enough stress for a long enough period of time and feeling helpless enough, powerless enough, you can also see flop show up in more complicated behavioral patterns. So when someone submits to a place where they're just in that workaholic position, or in a really, really highly conflictual relationship without seeing any opportunity to escape, or in really chronic, long-term, intractable depression, mood disorders, or anxiety, those sometimes, or mood disorders usually, they can be evidence of really unresolved trauma, and the brain and body just coming to flop, or in this case, submit to, or just accept that this is an inescapable threat and danger. So I will just accept it, submit to it, and just put my head to the ground and keep going. So, so those are far more complicated. And if anybody's in the position of wanting to know more about that, those are definitely conversations that can be, helpful to get a little bit more education, be in touch with a professional who can kind of help you think through what signals and patterns you might have in your own world. But in a cancer situation, if you're in the position of already being in flop or that submit, imagine a cancer diagnosis coming in on that, right? Like your brain and body have already determined that this is insurmountable. And now you're dealing with cancer or you're caring for a loved one. So that's a really overwhelming time and important to be in touch with support if you're in that position of seeing flop in your world.
Well, and I think that one of the challenges I think with trauma is that, you go the 5 F's, right? You get into that state, that sort of protective survival state, and then you don't know how to get out. So there's not that flexibility, right? Because maybe in the short term, the flop may be completely productive when you have to acquiesce to having an MRI, say, right?
Right.
But are you able to then move out of that response, or do you just sort of stay stuck there with no relief and no kind of regrounding after having went to that state?
Right. I think you're pointing to, again, one of my most favorite and persistent and even probably overly repetitive conversations with folks, which is making friends with our survival mode. That flop does serve that purpose. What other choice do you have but to go through an MRI or to face a life-changing surgery, life-saving, life-changing surgery? So there really can be a very functional purpose behind flop or any of these 5 F's. They all serve us in some way in that moment. So it's coming to have compassion around how they come about, but then also coming to recognize and be able to identify when safety has returned enough in the environment to begin to start coming back down to a place of more self-regulation, and kind of responding more genuinely, more authentically, and more in the moment to the stressors that are around you, or rather your day-to-day life, as opposed to responding to that stress that's sort of still locked in the brain and body and telling you flop or submit or whatever may have been the case.
So I want to take a little pit stop here to talk about PTSD, because I think sometimes people come in and somebody has told them they have PTSD, or they come in and they say, I think I have PTSD, because I think we hear that phrase so often. Or of course, you also have the people that say somebody thinks I have PTSD, but I can't have PTSD because I'm not a soldier or something like that. I'm curious what your attitude is, or how you help people kind of understand what that, I mean, it's 4 letters, but I think there's a lot of meaning that gets associated with it.
Absolutely. So this could get deep and existential quick, but folks who work with me tend to know that I will use the phrase, I think the individual with whom I work is the best expert to what they need, right? Like, I'm not the expert in the room, they are. And so if someone comes to me and says, I think I have PTSD, or I don't want to have PTSD, or someone else says I have PTSD, what do you make of that, Dr. Salyer? I generally answer back with, I don't know, is that meaningful to you? I think there can be great value in labels sometimes, especially if it is, cancer very often, not always, but is much more that chronic, complex trauma. And so it is a little bit more of a slippery fish, so sometimes putting a label on it and really saying, yes, this is true CPTSD, chronic PTSD, complex PTSD, or this is just PTSD. Sometimes there is something empowering in that labels it, it contains it, it makes sense of it. It can be really even liberating to finally put your finger on what is happening and to have it be seen, and that's a really important thing when it comes to trauma, is sort of bearing witness to, yes, in fact, this was a big deal. So sometimes PTSD and labeling is really one of the most healing things that we can do in trauma work. There are also, however, there are just as many other times where I would say to someone, labels are only useful if they're useful, like if they're useful to you, they can be very confining too. So, especially with the way that trauma can present so very differently one person to the next, having that sort of that superficial sort of artificially made checkbox listing of, do you have enough intrusive thoughts or flashbacks? Do you have, sometimes that also can feel limiting. So I would be really more inclined to take the lead of the person with whom I'm working. Is that helpful to you to be labeling that as PTSD? In trauma work, oftentimes there's a lot of normalizing PTSD, or rather trauma. I should go back to that. Trauma it's often seen more as a brain mechanism, brain injury, some would say, but really just a brain programming. And not so much this sort of mental disorder, mental illness, even in that sort of capital M way. And so when we give it a label as PTSD, people often will associate a lot of different things to that. So I will remind that individual with whom I'm working that it's most important that what we do and how we label, or the words we use, have value and are meaningful and helpful to you in making sense of things, and have much less to do with whether or not you fit a DSM criteria, whether or not because again, PTSD, just in our conversation today, it's good example and evidence that people associate things with PTSD, that you won't like the sounds of fireworks at the 4th of July, or, you have to meet a certain criteria. So ultimately, when someone has that conversation with me, it's a chance for me to involve them in a more meaningful conversation around what's important to you. Is that label helpful? How does that serve you? And in a lot of trauma clinicians' views, trauma is just part of living. Like that's, as we move through this world, you're going to encounter high emotional states of stress. And so the more we can normalize that, but also learn and do something with it, the better off we all are. So we're often very destigmatizing in the work that we do, very normalizing, kind of trying to meet folks where they're at and saying what works for you, because their brain is programmed to do the five F's just as much as mine is and yours is, and the next person. We're all wired in this survival based way. So it's really much more about just, I try to provide the manual to the brain a little bit and help that individual to find their map, their way to what works for them. And sometimes that means a full-blown label, sometimes it does not.
Yeah, well, and I think the other thing too, like, I think there's if you think PTSD, like technically is really saying you have these symptoms and you have to meet this certain criteria. And I think there's also the vernacular of talking about PTSD, which is not necessarily about meeting those criteria. It's just a sort of idea that like I've been traumatized. And I think just because you don't meet the criteria for PTSD does not mean that there is not healing needed after going through something traumatic.
Absolutely. Well said. Ditto. Yes, I concur.
So we have a few minutes left here, and I feel like we could probably have a whole nother time to talk about this. But I know, of course, people, when they're dealing with these responses, I was going to call them symptoms, but I don't want to go in that direction. But when people are dealing with these responses, it's causing them distress. It's not working for them. What do they do? Right? Like what are the pathways for healing following a trauma?
Mm-hmm. Oh boy, there could be any number.
So 4 minutes, just
right,
4
4
minutes. If you could just give me a complete summary of all of the different ways that you can heal trauma, and go. No, I'm joking because it's a complex question, but I'm curious, like if somebody wanted to move in that direction to address some of the trauma that they currently experienced, or maybe they want to go back and work on trauma that they realize there's still some work to do. What would you suggest as some first steps?
Mm-hmm. So I have a couple of sort of louder messages that I want to make sure I sneak in these 4 minutes or less.
Okay.
there could be a million answers.
You don't like my question, Katie?
There could be a few million answers to that, but I'll focus on the ones that feel really important to me that I'd want to make sure someone has in mind. I think trauma work, very importantly, cannot be forced. It's, as we talked about before, meeting a fire alarm and walking up to a fire alarm and screaming at it to stop is not going to make it stop. So, there's no such thing as forcing your brain and body into complying. It often can actually just add more challenges to the mix. So I would really make sure that an individual takes the time to think about, consider where they are in life, the type of support they have around them, and ultimately feels committed to doing trauma work. It can be hard. It can be really hard. Sometimes it gets harder before it gets easier. And that's normal to the process, but it's a commitment. And so really being thoughtful about how you want to enter into that trauma work leads me to another really, really important message I want to bring. And that is trauma work is often very different from more typical talk therapy. There are a lot of very particular kind of lenses or pieces of information that might be about the biology of the brain and body, or about how to navigate those systems, or there's a lot to it that I think it can be really, really helpful to make sure that the personal, if you're going to pursue this with a professional support, which is really best advised, that you make sure that professional is trauma informed. We have an amazing field of psychology with so many different expertise and directions and focus that you couldn't find in a professional. If you are believing that there could be trauma in this present day and that cancer experience, or in that history, I would really encourage you to find someone who's going to have some expertise in that particular area, that trauma informed perspective. So those things are pretty primary. I'm glad I at least got those two in there. I'll try to sneak in as well. Trauma work may look different from traditional talk therapy. We said earlier how this brain is, there's that top-down processing is what we would consider more traditional talk therapy, where we're talking frontal lobe to frontal lobe. We're using words and cognitions, and, we're trying to think of things in a particular way. But that is working against the wiring of this bottom-up trauma processing sort of perspective. So sometimes you'll find professionals who may present to you options for other ways of working, and rattling off just some of any number could be things like, folks are often familiar with hearing about EMDR, brain spotting, sometimes internal family systems. There can be a lot of different somatic experiencing, different ways. Yoga therapy is more and more familiar. You'll recognize that a lot of these different experiences have much more of a body-based sort of somatic, they call it somatic experiencing, or somatic kind of intervention style. And they just impact you differently. They kind of like, it's like scratching the itch a little lower in the brain, and can be a little differently effective at reaching and changing things. Though talk therapy, if that is your preference, if it's comfortable and familiar, is also perfectly valid. So there could be any number of additional answers, but I'm also conscientious of our time. I'd encourage ultimately for you to get in touch with that good professional and solid expertise, even if you're still in that place of being more kind of checking in and contemplating that step for yourself, educating yourself with some articles and resources from reputable websites. The Cancer Wellness Center is itself a phenomenal resource with amazing professionals, some of whom may dabble more in the capital T traumas, and some who also are just really well informed with that cancer experience. So that's a great way to find some targeted expertise about this trauma that may be going on. And make sure that they're a trusted resource, and if need be, they can direct you to more trusted resources.
I think that's such an important message, that if you're going to be dipping your toe in it, a really good starting point is to find that professional that can, if not provide the therapy, at least provide some guidance to make sure that you're going to move in a healthful direction versus feel like you're adrift out in the ocean by yourself. So maybe, thank you for being here. Maybe I'll convince you to come back again and talk about something else.
Me too. It's very nice seeing you again.
Yeah,
Cancer Wellness Center. Very, very, very honored to be asked to come in and chat.
And if people wanted to find you, where could they find you?
So I do provide services at 360 Wellness and Coaching in Lake Forest currently, which is very much telehealth, as is much of the nation. The information can be found at the website, www.360wc.com, or as with many professionals, you can find me on Psychology Today. Thank you very much for having me.
Yeah, thanks so much for being here. And I see Savina was kind enough to put up the website in the chat for anybody who's interested. So I want to thank Katie. I want to thank all of you who joined us here on Zoom, on Facebook, who may be watching this on YouTube. We will not be here in December. We're taking a little holiday break, but I will be back here in January to talk with Elissa Siegel, who is the Cancer Wellness Center's new child life specialist. The date is to be determined, so check the center's website if you're interested in joining us for that. Thank you all. Take care and have a wonderful Thanksgiving and holiday season. Thanks, Katie.
Thanks.